Hello everybody. Today's lecture will be about diseases of the joints. We will not cover all joint diseases, but we will cover some of the commonly encountered disorders of the joints. The first one is they are divided into subcategories. Degenerative diseases, the best example is osteoarthritis اللي هو تآكل المفاصل. And the second group is immune-mediated injury. The best example on this is rheumatoid arthritis, التهاب المفاصل الروماتيزمي. And the third group of disorders is the infections. We call it infectious arthritis or septic arthritis. There are many other diseases of the joints like deposition diseases like gout and pseudogout أو مرض النقرس. وفي عندنا tumors of the joints, but we will not cover these aspects. So we will start with osteoarthritis. From its name, it is an itis, so it means there is an ongoing inflammation. However, the basic change in osteoarthritis is degeneration of the articular cartilage, تآكل الغضروف في المفصل, and the inflammatory changes are secondary. So it's not a primary inflammatory disorder, it's a degenerative joint disease. It is considered the most common joint disease. It is considered sometimes part of the aging process. And it can cause physical disability and inability to walk or inability to move the joints, especially in patients over the age of 65. The basic change in osteoarthritis is in the articular cartilage. So there is a degeneration due to aging, and any structural change in the underlying bone is considered secondary. So المرض الرئيسي بيكون في الغضروف. Before we start talking about osteoarthritis, we have to understand the function of the articular cartilage. The articular cartilage permits a friction-free movement along with the synovial fluid. يعني inside the joint we have synovial fluid اللي هو السائل هلامي داخل المفصل. We have the cartilage the cartilage with the synovial fluid they permit a friction-free movement عشان ما يصير احتكاك بين سطح الغضروفين اللي بيكونوا lining the ends of the bone. So if we are talking about the knee joint, we have the articular, the cartilage covering the distal femur, and a cartilage covering the proximal part of the tibia. So both of them, when we move the knee joint, they will slide over each other, and because of the presence of this cartilage with the synovial fluid, there will be no friction. فهذا بيحمي الجوينت. The second function of the joint cartilage is the spread the load or the weight of the body over the joint. So إذا الواحد وزنه عالي أو صار في trauma, this cartilage will يعني بيحمل وزن الجسم. Osteoarthritis is not exclusively a wear and tear phenomena. But the mechanical stresses plays an important part in the disease, plus the aging. So هي زي عوامل الحت والتعرية. فمع التقدم في العمر ومع زيادة الحركة والميكانيكال ستريس على الجوينت بيحدث التآكل. Genetic factors also they seem to play a role, so it is a multifactorial disease. الميكانيكال stresses مع الايجنج مع some genetic factors اللي بتزيد susceptibility of the patient to this disease. So it's a multifactorial disease, لكن دائما بتكون لها علاقة بالايجنج مع بعض ال other factors that we will talk about. According to the underlying cause of osteoarthritis, we can divide osteoarthritis into two types: primary osteoarthritis and secondary osteoarthritis. The primary type is usually associated with the aging process بدون underlying or بدون non underlying causative or initiating factor. So it's an insidious disease, gradual onset with the advancing age. However, the secondary osteoarthritis دائما بيكون لها سبب. When do we think of secondary osteoarthritis is when the patient is young. If the patient is young, we start to think of secondary causes and predisposing conditions. Like if there is a previous trauma to the joint، إذا واحد صار عنده كسر involving the joint at some point of time، هاي التروما ممكن تؤدي إلى ال early appearance of osteoarthritis بهاي الجوينت، خاصة إذا ال fixation of the fracture كان inappropriate. Developmental deformities, for example patients اللي بيكون عندهم developmental deformities of the hip DDH أو اللي هو الخلع الوركي، هدول الناس اللي عندهم DDH if it is not treated بصيروا عرضة لل secondary osteoarthritis of the hip joint later on. Systemic diseases like diabetes, hemochromatosis, which is deposition of iron in the body and in the joints, or marked obesity. Obesity is considered a secondary risk factor، عشان هيك المرضى الأوبيس ممكن يصير عندهم osteoarthritis على عمر كتير صغير، وواحدة من أهم الفاكتورز اللي بتنحكى للبيشنتس الأوبيس إنهم يخففوا وزن، فهذا will alleviate السيمتومز ويخفف السيمتومز في الأوستيوارثرايتس. مين هي الجوينتس اللي more commonly affected؟ بتعتمد على إذا البيشنت male or female. In females, the knees and the hand joints, the small joints of the hands, are more commonly affected, but in males, the hip joints are more commonly affected. So you have to know the distribution according to the different genders. So regarding the morphologic changes in osteoarthritis, the earliest change starts with increasing the water content of the cartilage. The increase in water content in the cartilage leads to decrease in the elasticity، يعني بتقل المرونة تبعية الcartilage. This will lead to the formation of horizontal and vertical fibrillation and cracks، زي تصدعات في الغضروف in the superficial layers of the cartilage اللي هي بتحتك مع بعضها البعض. With time, the full thickness of the cartilage is lost, and this will lead to exposure of the subchondral bone اللي هو العظم الموجود تحت ال cartilage. So the end result is like when the two bones rub against each other when the joint is moving because of the loss due to the loss of the articular cartilage. With progression of the disease, there will be sometimes small fractures زي كسر صغير بpiece من ال articular cartilage and the subchondral bone. This small piece of bone and cartilage will be dislodged into the joint cavity وراح تصير تتحرك داخل ال joint cavity زي اللوز بنسميهم loose bodies or the joint mice. طبعا هاي ال small piece ممكن تعمل وجع، ممكن تعمل كريبتس أو طقطقة، ممكن تعمل لوك للجوينت، المريض ببطل يقدر يحرك رجله for example if you're talking about the knee joint. Also of the secondary changes اللي بتصير مع الوقت اللي هي the appearance of mushroom shaped osteophytes بنسميهم. It's like a bony outgrowth، بروز عظمي أو نتوء عظمي at the margin of the articular surface. طبعا هاي الاوستيوفايتس راح تعمل impairment للموفمنت بشكل أكبر. So the progression of the disease راح يصير عندنا الوضع أسوأ. لكن one of the most important features of osteoarthritis is that there is no fusion of bone. No fusion of bone even with the progression of the disease. That's why there will be no joint deformities. So in this picture here, you can see that this is the articular cartilage and this is the underlying bone. You can see here the vertical cracks، التصدعات اللي بتصير موجودة في الكارتلج with time, and look to the surface, it's no longer smooth. Here you can see here the articular cartilage, the whitish in color. Look here at the periphery of the joint, but on the articular surface where bones rub against each other there is loss. فهنا ضل يقل ال thickness of the cartilage لحد ما هنا صار في عنا complete loss of the articular cartilage and this will cause exposure of the underlying bone اللي بنسميه ال subchondral bone يعني the bone below the cartilage, formation of these cysts, fluid filled cysts. فبصير البون exposed لل fractures and ممكن يصير في outgrowth هنا like osteophyte زي المشروم like، وممكن يصير في fracture of part of the bone with the articular cartilage يعمل عنا الجوينت mice. So what are the clinical features of osteoarthritis? The most important thing in osteoarthritis is that it is an insidious onset, insidious disease, gradual disease. يعني الأعراض ما بتيجي فجأة، هي بتبلش mild وبعدين بتصير moderate بعدين بتصير more severe with advancing age. Predominantly, this disease affects patients in their 50s and 60s, characterized by deep aching pain, exacerbated by the movement or the use of the joint, and it is relieved by rest. يعني بيجي المريض بحكي بس أمشي أو بس أتني إجري بتوجعني، بس لما أقعد أرتاح بيروح الوجع. This is typical. The distribution of joints زي ما حكينا بيعتمد على الجندر. Knee joints والjoints of the hands are more commonly involved in females بينما hip joints affects more commonly involved in males. Another feature or symptom is the morning stiffness. أول ما يصحى المريض الصبح بيحس إنه مفاصله متيبسة. كريبيتوس اللي هي طقطقة الجوينت لما يحركها المريض، والسبب في ذلك إنه الساينوفيال فلويد بقل والارتيكولار cartilage is lost. limited range of movement بتقل مستوى الحركة، ببطل يقدر يتني رجله كاملة أو يمدها بشكل كامل. الأوستيوفايت لما تتكون إذا كانت موجودة في الفيرتبري في العمود الفقري أو في الفقرات، these osteophytes لأنها برضو ممكن تتأثر بالأوستيوارثرايتس المفاصل الموجودة بين الفقرات. these إذا تكون osteophytes ممكن تعمل impingement أو تضغط على الفورامينا اللي بيطلع منها النيرف روتس، فبتعمل أعراض بتشبه أعراض الديسك برولابس، بتعمل لي radicular pain نتيجة الكمبريشن على العصب على النيرف، أو ممكن تعمل muscle spasm in the distribution of this nerve، ممكن تعمل muscle atrophy، أو ممكن تعمل neurological or sensory deficits in the distribution of the affected nerve. الjoints according to the in decreasing order of frequency hips, knee joints, lower lumbar and cervical vertebrae, proximal and distal interphalangeal joints. The proximal interphalangeal joint اللي هي في الهاندز and the distal interphalangeal joints، وبرضو عظام الفت الفيرست carbo-metacarpal joints وال first tarso-metatarsal joints of the feet. Sorry, the first carbo-metacarpal joints برضو in the hands and the first tarso-metatarsal joints of the feet. هدول هم البونز اللي أو الجوينتس اللي more commonly involved in descending order of frequency, and as I said the hip joints involved more in males while knee joints involved more in females. Other clinical features for osteoarthritis is the formation of Heberden nodes. شو هي الهيبردين nodes؟ اللي هي osteophytes when they form in the distal interphalangeal joints of the hands. الديستال interphalangeal joint اللي هي الجوينت البعيدة السكند joint اللي في الأصابع. And these Heberden nodes they form because of osteophyte formation at this site, and this is characteristically seen in females, in women. There is no predicted way to prevent the progression of osteoarthritis. ما بنقدر نوقف the progression of the disease, but we can stabilize it or slow it down by physiotherapy, for example, by إذا في أي secondary cause for osteoarthritis to treat it, like patients obese, they should lose weight. We can stabilize the osteoarthritis for years or slow the progression of the disease, but we can't prevent the progression at all. With time, there will be significant joint deformity can occur, although, as we said, there is no fusion of the bones of the joint can happen like what we will see in rheumatoid arthritis. وهي من الفروقات المهمة بينهم إنه ما في bone fusion وما فيش joint deformities إلا very late in the disease، والjoint deformities بتختلف عن اللي بنشوفها في rheumatoid arthritis. The second common joint disorder is called rheumatoid arthritis أو التهاب المفاصل الروماتيزمي. طبعا هنا the disease is totally different from osteoarthritis, although they may share similar sometimes symptoms regarding the pain, and sometimes it is difficult to differentiate between them, but we have many clues in order to differentiate between rheumatoid arthritis and osteoarthritis. The rheumatoid arthritis is a chronic autoimmune inflammatory disorder, and it's not a degenerative joint disease that is related to aging. Usually it affects people at any age, but the peak incidence is the second to fourth decades of life. So you can see that it is the age أصغر من ال patients اللي with osteoarthritis اللي بالعادة بيكونوا in 50s and 60s. Primarily, rheumatoid arthritis بيأثر على the small joints of the hands and feet. So it's not the knee joint, not the hip joint. They are the small joints of hands and feet. The primary disease in the joint is in the synovial covering. There is primary synovitis or synovitis, inflammation of the synovial membranes. This inflammation of the synovial membranes will secondarily involve the articular cartilage. يعني مختلف عن osteoarthritis, where the disease primarily affects the cartilage with secondary involvement of the subchondral bone. Here the disease starts in the synovial membranes covering the joint from the inside, causing synovitis, inflammation of the synovial covering, with secondary involvement of the articular cartilage and damage of the cartilage, وبعدين late of the bone with the fusion of the bone. Females are affected more commonly than males, والratio عالية 3 to 1 or to 5 to 1. So it's not common disease in males. No age is immune, but as I said, it's more commonly encountered in patients in their second to fourth decades. So a young lady is the typical history for rheumatoid arthritis. Now, regarding the morphology, rheumatoid arthritis is a symmetric disease. What do we mean by symmetric? Is that it causes bilateral involvement. يعني البيشنت تيجي بتشكي من both hands, both feet, both knees joints. إذا knee joints affected. The primary, mainly the disease affects the small joints of the hands and feet. However, ankle joints, knee joints, wrist joints, the elbows, the shoulders are all can be affected. Typically, the disease affects the proximal interphalangeal joints, not the distal ones, like in osteoarthritis. So in osteoarthritis, proximal and distal interphalangeal joints are affected. بينما in rheumatoid arthritis, it's only the proximal interphalangeal joint and the metacarpophalangeal joint اللي هي بين الأصبع الإبهام وعظم اليد. الديستال interphalangeal joints are usually spared، وهي طريقة عشان نفرق بين osteoarthritis والrheumatoid arthritis. الaxial skeleton اللي هي involvement of the spine is usually limited للupper cervical spine. بينما lumbar spine, thoracic spine are usually not involved in rheumatoid arthritis. The hip joint involvement is extremely uncommon, unlike in males. Osteoarthritis primarily affects the hip joint. So the distribution of joint involvement helps us to differentiate between osteoarthritis and rheumatoid arthritis. دائما لما يجي الديزيز symmetrical involving the small joints of the hands and feet, where the proximal interphalangeal joints are affected while distal are spared, we start to think more of rheumatoid arthritis. Another feature is the chronic synovitis, inflammation of the synovial membranes. This, because of the inflammation, we will have the cardinal signs of inflammation, that is edema and pain and hotness. So لما تيجي المريضة with rheumatoid arthritis بيكون الشكوى مش بس الألم زي in osteoarthritis. There will be edema and swelling of the joint with redness and hotness. إذا الانفولفمنت كانت للهاند جوينتس راح نشوف fusiform swelling of the proximal interphalangeal joints بيكون شكلهم زي شكل الskeletal muscles fusiform swelling. With the progression of the disease, articular cartilage will be eroded and affected and eventually may be destroyed with damage also to the subchondral bone. So as I said, subarticular bone or subchondral bone may be attacked and eroded secondarily with the progression of the disease. In order to diagnose rheumatoid arthritis, we rely on the history and the physical examination, the findings of symmetric involvement of the joints with the swelling, hotness, and redness of the joints, in addition to some X-ray findings. The hallmarks for the rheumatoid arthritis on X-ray على صور الأشعة: joint effusions, accumulation of fluid inside the joint, juxta-articular osteopenia, the density of the bone under the articular cartilage is decreased. There is narrowing of the joint space, and there is loss of articular cartilage with the progression of the disease. The tendons, the ligaments, and the joint capsule may be destroyed with the progression. Also, this will lead to joint deformities. And of these deformities, the radial deviation of the wrist toward the radial side, and the ulnar deviation of the fingers, flexion hyperextension abnormalities of the fingers that are the swan neck deformity and the boutonniere deformities, which I will show it to you in the next slide. These deformities are characteristic for rheumatoid arthritis, and we don't see them usually in for rheumatoid arthritis, and we usually do not see them in osteoarthritis. This is the first deformity of the hand joints in patients with rheumatoid arthritis, which we call it boutonniere finger deformity. هدول بنسميهم الفlexion extension deformities. Due to the disruption of the tendons overlying the joints, we will have a fixed flexion of the proximal interphalangeal joint with hyperextension of the distal interphalangeal joint. These are the proximal interphalangeal joint and the distal interphalangeal joints that I told you about. The other deformity is the swan neck deformity. When I say deformity, it's a permanent deformity due to a damage in the tendons around the joints. We will have here the lax hyperextension, the opposite, hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. Of the other clinical features for rheumatoid arthritis is the appearance of rheumatoid subcutaneous nodules. شو يعني subcutaneous؟ يعني بصيروا تحت الجلد, under the skin. We call them rheumatoid nodules. They affect only 25% of patients, but they are characteristic, and they occur along the extensor surfaces of the forearm or in areas subjected to mechanical pressure. Sometimes, or rarely, these rheumatoid nodules can be found in the lungs, in the spleen, in the heart, or even in the aorta. Clinically, these nodules are firm and non-tender, yani they are painless. Oval to round mass may be as much as 2 centimeter in diameter, and under the microscope they are formed of granulomas, rheumatoid nodules. In 80% of patients with rheumatoid arthritis, they have elevated levels of the serum autoantibody called rheumatoid factor. So, rheumatoid factor is present in 80% only of patients. So, we have 20% of patients with negative rheumatoid factor. So, we don't only rely on rheumatoid factor to diagnose rheumatoid arthritis. We should have many of the other clinical features. We have a criteria for the diagnosis. One of them is the presence of rheumatoid factors in the serum. If it is not present, this also will not exclude the diagnosis. These are the rheumatoid nodules. Look at their location at the extensor surfaces here at the elbow joint and the extensor surface of the hand. Subcutaneous nodules measuring up to 2 centimeters in diameter, and as I said, they are painless. To diagnose rheumatoid arthritis, we rely on the diagnostic criteria for the disease. Well, these diagnostic criteria are 7 in number, and at least 4 of these features need to be present for the diagnosis of rheumatoid arthritis. Yani, not any patient with a swollen hand joint is a rheumatoid arthritis patient. We should have many symptoms together in order to diagnose the disease. The first diagnostic criteria is severe joint pain with morning stiffness. So the patient tells you that when he wake up in the morning, his hand joints are stiff بيكونوا متيبسات. لكن with the progression of the day, the stiffness will decrease. We should have arthritis in 3 or more joint areas. And when I say arthritis, it does not only mean pain. We should have the swelling, the hotness, and the redness with the cardinal signs of inflammation. So multiple joints should be affected in order to diagnose rheumatoid arthritis. This is not the case in osteoarthritis where we could only have one joint involved. Arthritis of the small hand joints, symmetric arthritis, that is bilateral involvement of the left and right joints, the presence of rheumatoid nodules, presence of serum rheumatoid factor, and the typical radiographic changes that I told you about. If 4 of these criteria are present, then we can diagnose rheumatoid arthritis. The clinical course of the disease is characterized by the presence of constitutional symptoms in addition to the joint symptoms. These constitutional symptoms could be low-grade fever, malaise, تعب عام and weakness, enlargement of the joints and swelling of the joints with limited movement of the joints. Complete deformities may occur late in the disease. If we have a swollen joint, especially if it is the large joint involved by rheumatoid arthritis, it's not a common scenario. We usually the small joints are affected, but sometimes the knee joints or the ankle joints are also affected. If we aspirate the synovial fluid, this fluid will be sterile. There will be no bacterial or no microbial growth in it, which means that it is a non-infectious arthritis. This is important when we have only one joint involved, which is a rare scenario, and the differential diagnosis here is with infectious arthritis. So in order to exclude infectious arthritis, we aspirate the joint fluid، بناخد عينة من السائل داخل المفصل ونعمل عليه culture. So there will be no bacterial growth. This is typical for rheumatoid arthritis because it is an autoimmune disease, not an infectious disease. The last type of arthritis is the infectious arthritis. It is caused by infections, and microorganisms can lodge in the joint by different ways. The first one is hematogenous spread، يعني توصل للجوينت عن طريق البلد. What the second way is by contiguous spread from an adjacent osteomyelitis or adjacent soft tissue abscess. So the bacteria will gain access to the joint from an adjacent site of infection. Infectious arthritis is serious because it can cause rapid joint destruction and permanent deformities if not treated well. Acute suppurative arthritis is an infectious arthritis that is bacterial in origin. Anything that is suppurative بالعادة بيكون فيه formation of pus and it is bacterial. The causes for bacterial septic arthritis is differs according to the age group of the patient. In children under the age of 2 years, Haemophilus influenza bacteria predominates. In older children and adults, Staphylococcus aureus is the main causative agent. In late adolescence and young adulthood, gonococcus also may play a role. البيشنتس اللي بيكون عندهم sickle cell anemia مرض الأنيميا المنجلية they are prone to infections of the joints and the bone with salmonella species at any age. So salmonella salmonella um, osteoarthritis, salmonella arthritis is commonly seen in patients with sickle cell disease. The clinical features for infectious arthritis is different from osteoarthritis and rheumatoid arthritis. Because the disease here is not a gradual in onset, it is sudden in onset. Onset of pain, redness and swelling of the joint with restricted range of motion. ببطل البيشنت يقدر يحرك المفصل. Fever, high fever usually بتكون leukocytosis, elevated white blood cell count إذا البيشنت عملنا له فحص مخبري, elevated ESR, erythrocyte sedimentation rate, because it is an acute phase reactant or reaction, as if you remember from the inflammation lecture. In 90% of non-gonococcal suppurative arthritis, the infection usually involves only a single joint. The knee joint, followed in order by the hip joint, shoulder, elbow, wrist, and sternoclavicular joints. But the knee joint is the most commonly affected joint in infectious arthritis, and this is usually a single joint disease, not like rheumatoid arthritis, where we have multiple joints affected at the same time, principally the small joints of the hand and feet. بالعادة الانفكشس arthritis بتأثر على large joints مش small joints. If we aspirate fluid because the joint is swollen, if we aspirate fluid from the joint, the fluid is typically purulent, يعني زي البص عبارة عن عمل, and if we do culture to this fluid, we will grow the causative bacteria. These are the differences between infectious arthritis and other forms of arthritis like rheumatoid arthritis and osteoarthritis.